important topic is the operability of ovarian cancer and peritoneal cytology, TAS and PSO, mentectomy, lymph node sampling, peritoneal biopsies, appendectomy. These are all like compulsory surgical steps for people who are unaware of staging. It's through the FIGO staging, and FIGO has a very nice staging system. It's like very connected to operability, and like FIGO says, if one is involved, stage one, then it is only the ovary, and 1A is single ovary, 1B is both ovaries, B for both. Two in FIGO will always have two organs involved. So, which is the most likely organ along with the ovary? It would be two would be the ovary or tubes, with pelvic involvement. The pelvic or the peritoneal or primary peritoneal carcinoma would be stage two. So two is two organs. So two is 2A would be uterus and ovary, or 2B would be ovary and peritoneum, or 2C would be, you know, capsule rupture and peritoneal spill and malignant cells. So we have stage one of ovary, stage two of ovary, stage three would be again ovary, okay, one of both ovary, primary peritoneal carcinoma with peritoneal mets outside the pelvis and or retroperitoneum. So two would be contained inside the pelvis, like that, two intrapelvic. Three would be outside the pelvis. So what would be outside the pelvis? Outside the pelvis could be pelvic rim, it could be extrapelvic, stage three, or retroperitoneum. Okay. So now if you want to see the staging of 3A, 3A2, 3B, and 3C. Now, and then 4 is an advanced stage. So now, so 3 is, as we said, extra pelvic mets, which has to be very clear. And when you're talking about extra pelvic mets, the most common stage would be 3C. Now, in 3, 3A would be retroperitoneal mets. 3B would be larger retroperitoneal mets or macroscopic peritoneal pelvic mets up to 2 centimeters. Okay, and you can include the capsule of the liver or spleen, and 3C is, you know, macroscopic extraperitoneal mets larger than 2 centimeters. So if you have extraperitoneal mets which are microscopic extraperitoneal mets, you would put it as 3A2. 3B would be extraperitoneal mets which are large in size, which are macroscopic up to 2 centimeters, and 3C macroscopic extrapelvic mets, which is larger than 2 centimeters, is the most common stage. And 4 is parenchymal involvement. 4A would be pleural and 4B would be parenchymal mets. Okay. So that is inside the lung, inside the liver, inside the spleen, not in the capsule. Okay. So that's how stage ovarian cancer. Now, any ovarian cancer, when you're operating, the most important thing in ovarian cancer extent. And then you need to do, have to do you have to remove the omentum in the pelvis. You have to do lymph node sampling and you have to do peritoneal biopsies. Now, the most important thing in ovarian cancer is the surgical management. And if after cytoreductive surgery, you have a greater than 1 centimeter of residual tumor, it is suboptimal cytoreduction. If you have less than 1 centimeter, you have optimal cytoreduction and you have NED or R0 total cross reduction. As you can see, the best outcomes, your median overall survival is highest with NED. And then you have lesser and lesser based on residual disease. Now, there is primary debulking surgery for resectable, you know, ovarian cancer or interval debulking surgery after 3 to 4 cycles of neoadjuvant chemotherapy and secondary cytoreduction surgery. Now, the most important thing in having to decide if the ovarian cancer is operable or not is to look at the phagotic laparoscopic index, which will predict a score of greater than 8 is operable and score less than 8 is inoperable. Now, the most important thing of like deciding if a person can be operated or not is based on 11th radiological criteria, which will have diffuse small bowel mesentery involvement, large volume ascites, retroperitoneal lymphadenopathy, parenchymal liver or lung mets. So, if you have liver or lung mets inside, then it would become inoperable. Okay, and if you have mesenteric root infiltration, and it's a superior mesenteric artery root, then it will become inoperable. If you have diaphragmatic and pleural disease, it becomes inoperable. If you have, poor ECOG status, extensive peritoneal implants with loss of fat planes, small bowel mesentery, and if there is, second, if there is bowel obstruction, and these become inoperable. So in these cases, you have to go for neoadjuvant chemotherapy and you'll have to go for interval debulking surgery. So this is how you approach the surgical overview of ovarian cancer. There will be more, but this is a quick talk.